The scent arrives first. Carbolic acid, sharp and astringent, cutting through the heavier undertones of unwashed linen, old blood, and the peculiar sweetness of chloroform-soaked cotton wadding. This is the olfactory signature of a London teaching hospital in 1890, a place where the boundary between healing and horror remains perilously thin, where the Hippocratic oath collides daily with the brutal limitations of Victorian medical knowledge. The grand entrance hall, with its vaulted ceilings and marble busts of long-dead physicians, projects an illusion of scientific mastery, but venture beyond those polished doors, and you enter a realm that would be unrecognizable to the modern eye. A landscape of suffering so visceral that even the most hardened contemporary observer would struggle to maintain composure. The surgical theater sits at the heart of this temple of pain, a tiered amphitheater where medical students crowd shoulder to shoulder on wooden benches worn smooth by generations of aspiring doctors, their notebooks open, their faces a mixture of fascination and barely concealed nausea. Below them, under the harsh glare of gas lamps that cast grotesque shadows across the operating table, a patient lies restrained by leather straps, conscious and terrified, because general anesthesia remains a luxury reserved for only the most extreme procedures, its risks still imperfectly understood, its application more art than science. The surgeon, dressed not in sterile whites, but in a blood-stiffened black frock coat that he wears as a badge of honor, the stains accumulated over years of operations serving as proof of his experience, approaches with instruments that have been wiped clean but never truly sterilized, the germ theory of disease still fighting for acceptance in the conservative bastions of British medicine. Joseph Lister's revolutionary antiseptic technique, introduced 2 decades earlier, has gained traction, but its adoption remains patchy, resisted by older practitioners who view the elaborate rituals of carbolic spray and phenol-soaked dressings as unnecessary theater, preferring instead to trust in speed and manual dexterity honed over thousands of procedures. The patient's screams, muffled by a leather bit clamped between the teeth, provide a rhythmic counterpoint to the surgeon's running commentary, his voice projecting to the students above as he describes each incision, each manipulation of tissue, treating the human being beneath his hands as little more than an anatomical demonstration. The speed is extraordinary, necessity born of an era before reliable pain management, when a surgeon's reputation rested on his ability to amputate a limb in under 3 minutes, the saw moving through bone with a sound that students would hear in their nightmares for years afterward. But even this violent efficiency cannot guarantee survival, because the greatest killer in these marble halls is not the disease itself, but what comes after. The invisible enemies that colonize wounds and incisions, turning minor procedures into death sentences. Puerperal fever stalks the maternity wards like a vengeful spirit, claiming the lives of new mothers at rates that would be considered catastrophic today. Their deaths attributed to miasmas and constitutional weakness rather than the unwashed hands of the attending physicians who move directly from autopsy room to delivery suite without pause for cleansing. The architecture of the hospital itself seems designed to amplify suffering rather than alleviate it. The long Nightingale wards stretching endlessly, rows of iron-framed beds packed so closely that infection spreads like wildfire through the crowded spaces. The patient's coughs and moans, creating a symphony of distress that never ceases, day or night. Ventilation comes through windows opened regardless of weather. The prevailing medical wisdom holding that cold, fresh air prevents the accumulation of poisonous vapors, even as patients shiver beneath thin blankets, their pneumonia worsening in the drafts. The nursing staff, mostly working-class women trained through grueling apprenticeships, move through this landscape with a stoicism born of necessity, their duties extending far beyond medical care to include emptying chamber pots, scrubbing floors, and maintaining the rigid hierarchies that govern institutional life. Florence Nightingale's reforms have begun to transform the profession, elevating nursing from menial labor to a calling that demands discipline, cleanliness, and a semi-religious dedication. But the ideals promulgated in her training schools collide constantly with the grim realities of understaffing, inadequate resources, and the sheer volume of human misery concentrated within these walls. In the fever wards, patients delirious with typhoid or scarlet fever thrash against their restraints, their bodies burning with temperatures that climb to lethal heights, while doctors debate the merits of bleeding versus cold baths, treatments rooted more in tradition than evidence. Tuberculosis claims entire families, the White Plague spreading through the tenements of industrial cities and arriving at the hospital in its advanced stages. When little can be done beyond palliative care, the patients' hollow coughs echoing through the corridors as their lungs slowly disintegrate. The asylum wing, separated from the general wards by heavy locked doors, houses those deemed mad or feeble-minded, their conditions ranging from true mental illness to epilepsy to simple poverty-induced desperation, all treated with the same blunt instruments of restraint, isolation, and occasionally experimental procedures that border on torture. Hydrotherapy, the application of high-pressure water jets to induce shock and compliance, leaves patients traumatized and sometimes physically injured, while the rest cure, prescribing absolute bed rest and social isolation for nervous women, often worsens the very conditions it purports to treat. The photographs that survive from this era, produced using the recently perfected dry plate process, capture scenes of such stark suffering that they seem staged for maximum dramatic impact. Yet they represent unvarnished reality. The child with rickets, his legs bowed into grotesque arcs from vitamin deficiency. The burn victim, his face a mass of scar tissue before the development of skin grafts. The cancer patient, the tumor visible as a distorting bulge beneath the skin, inoperable and inevitably fatal. These images, displayed in medical journals and teaching collections, serve both as documentation and as a kind of moral theater, illustrating the stakes of the medical profession's ongoing struggle against disease and death. The Pharmacopoeia of 1890 contains both genuine breakthroughs and dangerous nonsense, morphine and cocaine available without prescription, marketed as cure-alls for everything from teething pain in infants to depression in adults, creating epidemics of addiction that the medical establishment is only beginning to recognize. Mercury, that toxic heavy metal, remains a standard treatment for syphilis, administered until the patient exhibits signs of mercury poisoning, the cure often proving nearly as deadly as the disease. Radium, discovered just years in the future, will initially be hailed as a miracle cure and added to tonics and cosmetics before its devastating effects become apparent. The diagnostic tools available to the Victorian physician seem laughably crude by modern standards. The stethoscope, yes, invented decades earlier and now standard equipment, but X-rays still years away, blood tests rudimentary at best, and most internal conditions diagnosed through guesswork and physical examination, the doctor's experience and intuition serving as the primary guides. A skilled physician might recognize the signs of diabetes by tasting the patient's urine for its characteristic sweetness, a diagnostic method both intimate and primitive. Cancer diagnosis often comes too late for intervention, the disease detected only after it has progressed to visibility or palpability, the patient's remaining time measured in painful months. Childbirth, that most natural of human experiences, carries a mortality risk that modern women would find unthinkable. Complications like obstructed labor, hemorrhage, and infection claiming lives with grim regularity. The choice between mother and child sometimes forced upon desperate physicians working with forceps and hooks in dimly lit rooms where screams go unanswered. The infant mortality rate hovers above 20% in many industrial cities. Infectious diseases like diphtheria, whooping cough, and measles sweeping through nurseries and schools, leaving small coffins in their wake, the grieving parents advised to accept such losses as God's will and try again. Yet amidst this catalogue of horrors, genuine progress flickers. The development of sterile surgical technique begins to drive infection rates downward. The identification of disease-causing bacteria enables the first targeted treatments. The professionalization of nursing creates a core of skilled caregivers who transform hospital care from custodial warehousing to active treatment. The physicians of 1890 stand at a threshold, one foot still planted in the medieval past of humoral theory and heroic purging, the other reaching toward the scientific future of bacteriology and evidence-based medicine. Their daily work, a strange hybrid of superstition and cutting-edge research, of compassion and callousness, of genuine healing and iatrogenic harm. Walking through these wards today, transported by the magic of historical imagination, one would be struck not only by the visible suffering, but by the sounds. The constant murmur of prayers, patients and clergy alike seeking divine intervention where medicine fails, the clatter of instruments being cleaned in simple soap and water, the squeak of wheels on the medicine trolley bearing its burdens of laudanum and brandy, the arguments among physicians debating the latest theories published in The Lancet or the British Medical Journal. The smell of carbolic acid would cling to your clothes for days afterward, an olfactory reminder of a world where infection meant probable death, where surgical amputation was performed on kitchen tables, in tenement apartments, where the mentally ill were chained in attics, and the chronically sick were hidden away in institutions that resembled prisons more than healing centers. This is the landscape of 1890s medicine, simultaneously the culmination of centuries of gradual progress and the launching point for the revolutionary transformations of the 20th century. A moment when humanity had learned just enough to understand how little it truly knew about the workings of the human body and the nature of disease. When the gap between ambition and capability yawned widest, and when the images captured by pioneering medical photographers would indeed resemble scenes from our darkest fictional nightmares, except that every face, every wound, every suffering patient was terrifyingly, undeniably real.